Good afternoon, everyone, and welcome to today's webinar on lymphedema. This is Dr. David Kanashko. We'll be starting in about 10-15 minutes. However, I noticed a few of you are potentially listening in. So if you can hear my voice and the audio sounds good, if you can just type that in and send that out to me, I'd appreciate it, and we'll get started very soon. Thank you. Okay, I am back. Welcome everyone. It is 12:15 Eastern Standard Time, and my name is Dr. David Kanashko. I'm the Director of Education and Training here with Meditech Rehabilitation and Bioflex Laser Therapy. Today's webinar is on laser therapy for lymphedema, and a few housekeeping items before we start. This webinar is being recorded and will be rebroadcast on our support page at any time you'd like. However, of course, you do need it's password protected, so you'll need an appropriate username and password to access this webinar after the fact. If you have any questions, I will take them at the end of the webinar, but please type them in prior to that, and I will address them at the end. Please try and keep the questions related to today's topic. If you have other questions unrelated, you can email me, and I have my email at the end of today's webinar. Okay, so let's get started. I chose this topic because, number one, I haven't done it before, and number two, there's actually a lot of research on lymphedema and laser therapy. It's even in some guidelines to treat post-mastectomy breast cancer-related lymphedema. So there's actually really good evidence in supporting the use of low-level laser therapy for this type of condition. And I felt it was good knowledge, especially for clinicians that tend to work with these clients. Oftentimes they're massage therapists, but other manual therapists as well too. So today I'll present an overview of the lymphatic system just as a refresher. We'll go over the different types of lymphedema and some of the clinical research with respect to low-level laser therapy and lymphedema. Then I'll talk about how we approach treatment of this condition with our equipment. And lastly, I'll present a case study that sort of summarizes everything. And then we'll go into Q&A. So as you know, the lymph is a watery fluid. It circulates throughout the lymphatic system. It is formed when the interstitial fluid is collected through lymph capillaries. It is then transported through larger lymphatic vessels to lymph nodes, where it's eventually filtered by lymphocytes and then emptying back into the venous system. Notice that lymph capillaries is an important topic in this discussion because we do know that there's an action of vasodilation of capillaries, of circulatory capillaries, including lymphatic capillaries, that helps with the movement of lymph fluid. And this is one of the actions of how it actually works. So lymph is generally very similar to blood plasma. It returns proteins and excess interstitial fluid, as I mentioned, back to the bloodstream, but also it may contain bacteria, and these are eventually destroyed in the lymph nodes. So it acts as a filtering mechanism as well. Lymph can also transport fats from the digestive system back to the blood via chylomicrons. So as a review of the lymphatic system, as you can see here, you can see the different lymphatic channels and vessels, and you can see, which is really important with respect to where you'll be applying laser therapy, the lymph nodes, where they accumulate, for example, around the neck, around the axillary region, the antecubital fossa, then, of course, in the inguinal and iliac region, and a little bit lower down in the popliteal region. So these are areas that you need to know your anatomy fairly well when you're using the laser probe to be effective to stimulate them as well. And of course, this is what lymph nodes look like. You can see that there's afferent and efferent lymphatic vessels that drain into and exit the lymph node. Okay. So lymphedema is the swelling in one or more extremities that results from impaired flow of the lymphatic system. When the lymph vessels are blocked or unable to carry lymph fluid away from the tissues, then you can get localized swelling or lymphedema, which is obviously what we're talking about. This condition most often affects a single arm or leg, but can occasionally occur in both limbs as well. Most of the conditions we see are unilateral. So there's different types of lymphedema. Primary lymphedema is an abnormality of an individual's lymphatic system, and it's considered to be genetic, oftentimes present at birth or maybe come on a little bit later on. So there's three forms of primary lymphedema. There's congenital lymphedema, which is evident at birth. This is about 20% of the cases of primary lymphedema, and approximately, there are more females than males that have this type of condition. Lymphedema precox is the most common form of primary lymphedema. It is defined as lymphedema that becomes apparent after birth, and generally speaking, before the age of 35, and symptoms most often develop during puberty. Again, a higher increase ratio in females to males of 4:1. Primary lymphedema that becomes evident after the 35 years of age is known as Meige disease or lymphedema tarda, and this is the least common form of primary lymphedema. Secondary lymphedema, which is the one that we tend to deal with more commonly, develops when a normally functioning lymphatic system is blocked or damaged. In North America, by far the most common cause of this is secondary to breast cancer surgery or treatment. Oftentimes it's the combination of the two that causes this type of condition to occur. This usually results obviously in one-sided lymphedema, the side of the affected surgery and or treatment. So any type of surgical procedure that requires removal of regional lymph nodes or lymphatic vessels obviously can potentially cause lymphedema. Surgical procedures that have been associated with lymphedema include vein stripping, lipectomy, burn scar, excision, and peripheral vascular surgery. It can also occur due to trauma, burns, radiation treatment, infections, or even compression or invasion of lymph nodes by tumors. Worldwide, a condition called filariasis, which is a parasitic infection carried by mosquitoes. This is the most common cause of lymphedema. So really outside of North America, and especially in third world countries, this is what's going to be causing a lot of issues. And in fact, it's one of the leading causes of permanent disability in the world. So it is a very serious problem. However, here in North America, we probably won't see it very frequently. Although I imagine some people are listening outside of North America, and this may be appropriate for you. This affects millions of people in the tropics and subtropics throughout Asia, Africa, Western Pacific, and certain parts of Central and South America. So the parasite actually damages the lymphatic system, and this will lead to swelling in the affected arms, breasts, legs, and for men, the genital region. So lymphedema usually occurs in part of the body where lymph nodes have been removed or damaged by cancer treatment. So I'm going to focus on cancer-related lymphedema for the most part because that's where almost all the research has come from. However, it does have applications for other forms that we've talked about. So typically these areas include the axillary region, of course the underarm region, the neck, perhaps even the groin or the pelvis. But typically for breast cancer, it's going to be in the upper extremity. The risk of lymphedema increases with the number of lymph nodes that have been affected. So depending on how many nodes are removed, this will increase the likelihood of lymphedema. The stats are more than 1 in 5 women who survive breast cancer will develop unilateral arm lymphedema, and you can see the reference below where this comes from. So it's actually a very common problem, and unfortunately there's really no cure for this type of problem. You're dealing with an anatomical issue, and these women tend to have to deal with it for the rest of their lives. But there are, of course, ways of managing it, and laser therapy is one of those ways. So doctors usually classify lymphedema based on how the skin reacts to the touch, if swelling goes down when the limb is elevated, and if the skin is scarred or has changes to its texture. So if we look at these 3 grades or stages from 1, 2, and 3, you can see the first stage, which is the very beginnings of lymphedema. The skin will indent when pressed. The swelling will go down when the limb is elevated. However, there's no visible scarring. In grade 2 or stage 2, if the skin doesn't indent, the skin doesn't indent when pressed, swelling doesn't go down when the limb is elevated, and the skin has visible moderate to severe scarring. And the worst case, stage 3, is the skin has hardened and doesn't react to touch. The affected limb has swelled quite large in size and volume, and oftentimes there's changes in the texture of the skin. So symptoms can vary depending on the grade or the stage of lymphedema. So for example, symptoms of lymphedema include swelling, obviously, in the arm, leg, affected fingers or toes. There are oftentimes a feeling of fullness or puffiness or heaviness in the affected area. Oftentimes there's achy or burning type of pain in the extremity. The skin can appear shiny. Oftentimes, because of the edema, patients will have difficulties moving their limbs in the joints. There will be thickening of the skin, as I mentioned. There can be small blisters or growth that look like warts that leak clear fluid. The skin can pucker or looks like an orange peel. This is in more the later stages. Oftentimes, as we mentioned, the skin doesn't indent when pressed, and obviously clothing and or jewelry will feel quite tight over the affected area, and there may be some itchiness that goes along with that. As I mentioned, there's quite a few research papers on lymphedema and low-level laser therapy. I think there's about 6 or 7 randomized control trials and quite a few other papers that look into the mechanisms of how this works. I did want to first present a meta-analysis. This is published in the Journal of Cancer Survival in 2015, entitled Effective Low-Level Laser Therapy on Pain and Swelling in Women with Breast Cancer-Related Lymphedema. So they looked at 9 clinical trials, so it's a fairly robust meta-analysis, and they concluded that there was moderate to strong evidence, moderate strength evidence that supports the use of LLLT in the management of this condition, with clinically relevant within-group reductions in both the volume and pain immediately after the conclusion of LLLT treatments. We'll see as we go along that there's, the research pretty much shows that the results do last for longer than just right after the treatment, that you can actually get a fair amount of relief, long-lasting relief with laser therapy. They also concluded that the greater reductions in volume were found with the use of LLLT than in treatments without it. And the implications for these patients confers clinical meaningful reductions in both the arm volume and pain with women with this condition. So this is a really good paper to suggest that you should be using, along with manual lymphatic drainage techniques and other techniques, when you're treating patients with this condition. The next one I want to draw your attention to is published in 2011, and it's the treatment of post-mastectomy lymphedema with laser therapy, and it was a double-blinded, placebo-controlled, randomized controlled trial. So a good gold standard paper. They looked at 50 women that were diagnosed with breast cancer-related lymphedema. These patients were randomly assigned into 2 groups, either with the laser or with the placebo laser. They used 904 nanometer, so in the infrared range, a little bit higher up in the infrared range, but still acceptable. Relatively low power, and you can see they actually treated both the axillary and the arm areas. And the treatment was performed 3 times a week for 12 weeks. So that was a fairly lengthy treatment plan. And when you're treating these patients, be prepared that it will be a fairly long treatment plan until you get maximal recovery, at which point the patients oftentimes should be monitored, and they should have ongoing maintenance treatment to try and keep their edema to a controllable level. So lymph circumference, shoulder mobility, and grip strength were measured before treatment and at 4, 8, and 12 weeks. The primary finding is that laser therapy reduced the volume of the upper extremities, increased the mobility of the shoulders. Hand grip strength was improved with patients with post-mastectomy lymphedema, and they felt that these positive relief of symptoms were maintained at least during the period of the study. They didn't do a follow-up. So they suggested that the mechanisms of action for improving lymphedema were: 1, it aids in resorption of both microscopic and gross edema fluid. It increases lymphatic vessel diameter, as I mentioned earlier, because of vasodilation and contractility and lymphatic regeneration. These are all well-known mechanisms of action of LLLT. And it can stimulate phagocytic activity of neutrophils and monocytes in the lymph nodes. This is really important. We do know that LLLT has the ability to modulate white blood cells and improve the phagocytosis of these white blood cells. So it makes them more active and more efficient. They also suggested it can improve wound healing and reduce scar adhesion to underlying tissues, and can also even reduce the risk of skin infections. It does that by increasing the number of circulating white blood cells. Okay, next I wanted to draw your attention to another randomized control trial. This was published in 2017, so a fairly recent one by Stortz et al. In the Photodermatological and Immunological Photomedicine Journal. That's a handful. So they looked at 40 patients with unilateral lymphedema. They evaluated the effects of PBMT. Remember from my early webinars, my recent webinars, that I had mentioned that laser therapy is currently called photobiomodulation in research, and you'll be starting to see a lot more of the PBMT as opposed to LLLT. So PBMT, photobiomodulation therapy on lymphedema-related pain, quality of life, grip strength, and limb volume difference. So the subjects received irradiation for 10 minutes, so that's a fairly lengthy period of time. And they used a cluster laser covering this 78.54 square centimeters, and again at a fairly high infrared wavelength, 980 nanometers. I personally don't feel that's the ideal wavelength to use, but it will still be stimulatory with respect to cytochrome C oxidase and some of the other mechanisms of action. A total of 384 joules was applied during each session with an energy density of 4.9 joules per centimeter squared. The results, post-treatment, a 50% reduction in median pain scores and an increase in mean quality of life were observed. The mean grip strength was persistently higher after 8 sessions of PBMT compared to pre-treatment. However, they were not able to statistically find any changes over the course of time for mean grip strength. So they concluded that PBMT, using a compactly designed treatment regime in combination with a cluster laser device, did not significantly improve quality of life, pain scores, grip strength, and limb volume over the time of course. I feel I wanted to show this one because I felt that the wavelength they used was too high to really have the effect that we want. And this is where researchers need to kind of confer a little bit more with clinicians as far as the appropriate wavelengths. And these are in the guidelines set out by the World Association of Laser Therapy, recommending red in the range of 630 to 660, 680, and infrared around 780 up to 900 nanometers of wavelength. So before I move on, I did want to mention that if you go to cancer.ca website, there's an information session on managing the side effects of breast cancer, especially lymphedema. You can see the website below. And they actually did recommend laser therapy as among several treatments that the Canadian Cancer Society approves of. Now, there's quite a few others as well, but it's nice to see that laser therapy is there. And I know that I've had phone calls from patients that have read this information and have sought out treatment at our clinic. So I think it is something that you might want to put on your own personal website with respect to treatment of lymphedema. This will help patients when they see this type of information and go to your website that in fact this is a type of treatment that you do. Okay, so how do we approach our cases of lymphedema using BioFlex equipment? We do have a standard lymphedema protocol, and it's used for everything from post-mastectomy lymphedema to other causes that we've talked about, that I've talked about previously in the webinar. We use 5 minutes of red. It's usually set at continuous wave in the first stage. We'll start off with a fairly low frequency and duty cycle of 10 to 20, and we can work our way up to 50 to 80 within stage 1 for 7 minutes. And we'll use the laser probe. We can use it usually right off the bat at 100%, or you can maybe even reduce it a bit. And again, the time of the probe would depend on the number of areas that you need to treat. As well, the number of placements, here I'm showing you 2, 5 and 5, and 7 and 7, would be determined by the extent of the lymphedema and how many placements you feel you need to cover the lymphatic vessels. So just so I can make it clear, the array will be placed circumferentially around the extremity. If you have a long extremity, you might need 2 or 3 placements. If it's a shorter one, maybe just 2 placements. If it's the entire upper arm and lower arm, then of course you need more placements. But usually it's around the upper arm region, in which case 2, maybe 3 placements is adequate. You can even place an array in the axillary region, and the probe will be focused more on the lymph nodes. So the axillary region, the antecubital region in the upper extremity, on the lower extremity, the inguinal-iliac nodes, and I'll show you those shortly, as well as the popliteal region. Stage 2, you can start to see the intensity increasing and the frequency increasing. So we change the dual red to a modulated 100 hertz per second, or cycles per second, and 90% duty cycle, and anywhere from 50-50 up to 50-90 for the infrared. And again, the LDI 200 for 6 or as many minutes as you need. And the third stage, getting a lot higher in frequencies, you can see up to 5,000, even 1,000 for red and infrared. So that's how we approach the protocols. Some treatment tips that Dr. Khan has suggested. In stage 3, you may go to even much higher frequencies, especially with the dual infrared. Again, you apply in series of positions, moving from distal to proximal area. Okay, so you're going to start from, in the case of the arm, you'll start more around the antecubital region and work your way up to the axillary region as you're applying the arrays, and that also goes for using and treating the lymph nodes. He also says that the probe may not be required if there's no major focal area that you can detect. However, I think it's very helpful to still do the probe in most cases over the lymph nodes that are affected. And as I mentioned, you're going to use these large surface arrays in a circumferential fashion around the affected area. And the number of positions, again, depends on the affected area. He also suggested if vascular compression component exists, to also treat the terminal spinal cord and the autonomic nervous system specifically to help induce arterial dilation. So what he's suggesting here is to treat in and around the spinal cord, the affected spinal cord. So in this case, for mastectomy-related lymphedema, treating the cervical spine, or if it's a lower extremity, treating the lumbar spine. And if the area of involvement is extensive, then your treatment time will start to really increase. Minimally, these treatments are about an hour long. They may even approach an hour and a half or 2 hours long, depending on the extent of the problem. So just a little review so that you have a refresher. Obviously, you want to treat with the laser probe the axillary nodes, okay? And you also want to treat the nodes around the cubital region of the arm as well. So definitely you want to spend more time with your laser probe around these areas. Okay, I'm going to present a case study. 58-year-old female. She had a liver transplant in 1986, and this was as a result of hepatitis and hepatic failure. So she was diagnosed with chronic lymphedema of the left lower extremity, and she also had some accompanying cellulitis. And so you can see the etiology due to thrombophlebitis, anti-rejection of her medications, and hypoalbuminemia and gravitational dependency as well. So the findings, she had initially right leg mid-calf circumference 35 centimeters. and left leg mid-calf circumference of 43 centimeters. She wasn't with us for the entire duration of treatment. She was referred to another clinic. However, we treated her 9 times, approximately 1-hour sessions over 3 weeks. The outcome was we were able to reduce quite substantially by 5 to 6 centimeters of her left mid-calf circumference. The cellulitis essentially cleared up. And then, as I mentioned, she was referred to another clinic. So what we did here is what we treated around the affected area, but we also treated the probe at the axillary region, or sorry, at the inguinal and iliac region of the lymph nodes. And we also treated the popliteal lymph nodes as well with the laser probe. You're going to have to hold the probe for at least 6 to 10 seconds, if not longer, to allow enough energy density to enter into the lymph node. Here's the initial picture. You can see the cellulitis, and you can see the large extent of the lymphedema. Unfortunately, this is in a same front anterior view, but this was the final picture before she was released to another clinic. And you can see that there's less redness. The cellulitis was down substantially, although very difficult to tell. She did have a fair amount of decrease in lymphedema, the diameter of the lower leg. So in this case, we applied the array over the lower extremity, not over the thigh, and then we used the starting from the ankle distally and working our way up. So we have to apply 1 to the anterior, 1 to the posterior, and we did those sessions along. So you can see here, red was set a continuous wave. 5 minutes would have been the anterior shin, another 5 minutes on the posterior, another 5 minutes just proximal to that anteriorly, and another 5 minutes on the posterior aspect of the calf. And infrared was set at 10 to 20 for 7 minutes duration, and the probe was set at 100%, focusing on those lymph nodes. You can also try and focus on the lymphatic channels as well, but it's a little bit more challenging to get, to find that pattern of the channels in the leg. Treatments 4 to 6. You can see we increased the frequency and duty cycle of infrared to 50-50, keeping the other parameters approximately the same. And then treatment 6 to 9, we start to modulate the red light at 190, increasing the duty cycle or the energy density of the infrared to 80. And then she was released from care and sent to another clinic where she had ongoing treatment. Unfortunately, I don't have the results, the end results there. So that is our webinar for today. Let me just pull out some questions and see if you guys had a few questions here. Okay. So a question about what does severe scarring look like? So really the scarring oftentimes would be secondary to the surgery procedures. And depending how extensive the incisions were to remove the lymph nodes, you'll typically see the scarring over the region in the axillary region, even in the upper breast region as well. And if any other nodes were removed, you'll see the visible scarring. How many seconds should the probe be given? I think I did mention that you should be holding in the axillary region. Say, for example, I would expect to hold 5 to 10 seconds per point. In the cubital region over the elbow, maybe starting off at 5 or 6 seconds. You may not necessarily have to hold it quite as long. In the inguinal region, I would suggest holding it for a little bit longer, as well as the popliteal region as well. Another question is, are these studies on laser and treatment post-reconstructive breast surgery? Yeah, so these patients all had lymphedema secondary to mastectomies. All right, wonderful. Listen, thank you everyone for tuning in to today's webinar, and we will be doing our next webinar in December. If you're interested in coming to a training session, we do have a training session in December. If you want to go to our website at bioflexlaser.com. If you need to email me about any other further questions, I'm at david@bioflexlaser.com. So we'll see everyone next month, and in the meantime, stay healthy and make sure you laser your patients. Bye now.